Good afternoon, and thank you for joining us. Welcome to NCSL's webinar, Health Disparities in COVID-19. My name is Kai Nguyen. I'm a Senior Policy Specialist in NCSL's Health Program, and I'll be your moderator for today. Before we get started, I want to review a few housekeeping items. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through the chat box, so please feel free to type any questions you have at any point during the webinar in the chat box on the left-hand side of your screen. We will hold Q&A after all our presenters are finished. To begin building some comfort with the chat function and to learn who is on the line today, I invite you to type in the state from which you are calling now. Above the presentation, you will see a few tabs, with one labeled Resources. Here you can find and download a PDF version of the PowerPoint and a resource handout NCSL staff have put together. Another tab is labeled Speaker, where you can read the full bios of today's speakers. You can access these tabs at any time during the presentation. Today's webinar is being recorded and will be available on NCSL's website within the week. For those of you who may be joining us for the first time, NCSL is the bipartisan organization that serves legislators and legislative staff in each state and the U.S. territories. We provide research, technical assistance, and opportunities for policymakers to exchange ideas on the most pressing state issues, and we are an advocate for state rights in the American federal system. NCSL does not advocate for any policy, nor do we take positions on state issues. Now back to today's topic. Racial and ethnic minority groups are at increased risk of getting sick and dying from COVID-19. These racial differences in illness and death are not new or limited to the novel coronavirus, but the COVID-19 pandemic has highlighted and exacerbated long-standing disparities in health outcomes. Today, we will have a discussion with national experts about health disparities in COVID-19 and examples of state actions to reduce these disparities. I would like to take a moment to thank Amgen, an NCSL Foundation member supporting our work around women's health, chronic conditions, and health equity. Amgen's support allows us to provide up-to-date and relevant educational resources for state legislatures and webinars like this. Today, we'll hear from Dr. Jeffrey Hall, who will provide an overview of health disparities evident in COVID-19 and discuss how the pandemic has highlighted long-standing inequities in health outcomes. Then we'll hear from NCSL expert Tammy Jo Hill, who will provide a look at state actions to reduce these disparities. Last, we'll hear from Alicia Nelson, who will share how Ohio is working to reduce health disparities in COVID and beyond. We will have Q&A for all speakers at the end, but please feel free to put your questions in the chat box throughout the webinar. We are now ready to hear from our first speaker. Dr. Jeffrey Hall is the Deputy Director of CDC's Office of Minority Health and Health Equity and Chief of the Minority Health and Health Equity Team, also serving as Chief Health Equity Officer for COVID-19 response. Dr. Hall, thank you so much for joining us today. I'll hand it over to you.
All right, thank you. Hello, everyone. Thank you for inviting me to join you today. I'm Dr. Jeffrey Hall, the current Chief Health Equity Officer for CDC's COVID-19 response. As you heard, I'm also the Deputy Director of CDC's Office of Minority Health and Health Equity. Today, I will help to set the stage for what we know about who is placed at risk for COVID-19. I'll also describe how CDC is responding to health disparities during the COVID-19 pandemic. CDC is working hard to address increasing COVID-19 health disparities. The population health impact of COVID-19 has exposed decades, if not centuries, of inequities that have undermined the physical, social, material, and emotional health of racial and ethnic minority populations, as well as other population groups bearing a disproportionate burden of COVID-19. To accelerate progress towards reducing COVID-19 disparities, CDC established the Chief Health Equity Officer Unit in the COVID-19 Incident Management Structure. This unit's sole focus is to ensure an all-of-response approach to identifying and addressing health disparities. This is the first time in the agency's history that a senior leader was placed on the incident management leadership team with this specific focus in mind. Before introducing the data and CDC COVID-19 health equity strategy, I want to ensure that we are grounded by key definitions of health disparities and health equity. We define health disparities as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Moreover, health disparities adversely affect groups of people who have systematically experienced greater obstacles to health. We are working to achieve health equity, which we define as when everyone has the opportunity to be as healthy as possible. This is accomplished when we value everyone equally. Social determinants of health are the conditions in the places where people live, learn, work, and play that affect a wide range of health and quality of life risks and outcomes. CDC works to provide the public with current and near real-time data on COVID-19. A main way that this is accomplished is through the COVID data tracker. This tool includes COVID-19 data from several sources. Each source of data may have specific limitations. Here, you can see that there have been a total of over 7 million cases through October 9th. Information is also provided about total deaths as well as for total reporting jurisdictions. This information is updated daily. Please note that these data are total cases based on aggregate counts of COVID-19 cases reported by state and territorial jurisdictions to the CDC since January 21st, 2020. The numbers are confirmed and probable COVID-19 cases as reported by U.S. states, U.S. territories, New York City, and the District of Columbia from the previous day. Case numbers reported on other websites may differ from what is posted on CDC's website. This is because CDC's overall case numbers are validated through a confirmation process with each jurisdiction. Laboratory testing data through October 9th show that approximately 123,094,477 total tests have occurred. The data presented on lab testing represents viral COVID-19 laboratory test results from laboratories in the United States. This includes commercial and reference laboratories, public health laboratories, hospital laboratories, and other testing locations. The data represent laboratory test totals, not individual people, and exclude antibody and antigen tests. This slide presents information from COVID data tracker on cases and deaths by racial and ethnic group. CDC is working with states to provide more information on race ethnicity for reported cases. The percent of reported cases that include race ethnicity data is increasing. These data only represent the geographic areas that contributed data on race and ethnicity. Every geographic area has a different racial and ethnic composition. These data currently presented are not generalizable to the entire U.S. population. Percentages displayed in the charts represent the percent of cases or deaths for which the demographic variable of interest is known. Data on COVID-19 deaths are also reported to the National Center for Health Statistics via death certificates. These are from several separate data systems that typically live in different parts of a health department. Reporting jurisdictions work to make sure that these data agree, but that typically takes some time as information flows between departments. Reporting jurisdictions are always updating their data, and those updates get sent to CDC as soon as they occur. This graph shows racial and ethnic disparities in COVID-19 mortality from death certificate data. The bars represent the difference between the percent of the entire U.S. population made up by each group and the percent of COVID-19 deaths made up by each group. For example, the first set of bars shows the size of the disparity for Hispanics. Hispanics make up 20% of the population aged 35 to 44, while making up almost 50% of deaths in this age group. So the bar for the 35 to 44 age group shows a difference of 30% between the portion of the population and the portion of deaths made up of that group. The Coronavirus Disease 2019 Associated Hospital Surveillance Network, or COVIDNet, is a population-based surveillance system. It collects data on laboratory-confirmed COVID-19 associated hospitalizations among children and adults through a network of over 250 acute care hospitals in 14 states. Examining age-adjusted COVID-19 associated hospitalizations by race and ethnicity, we see that rates are 375, 367, and 367 per 100,000 population among Hispanic or Latino individuals, among non-Hispanic Black individuals, and among non-Hispanic American Indian, Alaska Native individuals, respectively. This is compared to 82 per 100,000 population among white individuals. Data has shown that racial and ethnic minority groups with conditions such as asthma, obesity, diabetes, chronic kidney disease, severe obesity, coronary artery disease, history of stroke, and COPD are at even higher risk for severe COVID illness. Severe illness here means that the person with COVID-19 may require hospitalization, intensive care, or a ventilator to help them breathe. They may even die. As you can see, some racial and ethnic minority groups are being disproportionately affected by COVID-19. Factors that may contribute to increased risk of getting sick and dying from COVID-19 include discrimination, working conditions, healthcare access and utilization, occupation, lack of educational opportunities, income and wealth gaps, as well as substandard housing. Discrimination, which includes racism, can lead to chronic and toxic stress and shapes social and economic factors that put some people from racial and ethnic minority groups at increased risk for COVID-19. Occupation plays a significant role in this epidemic. People from some racial and ethnic minority groups are disproportionately represented in essential work settings, such as healthcare facilities, farms, factories, grocery stores, and public transportation. Some who work in these settings have more chances to be exposed to the virus that causes COVID-19. It is also important to consider factors that influence access to medical care during the pandemic. Inadequate health insurance coverage is a major barrier to medical care, and unequal distribution of coverage directly impacts health disparities. Unreliable transportation also plays an integral role in persons having difficulty accessing health care. A lack of transportation, for example, leads patients, especially people at increased risk for severe illness from COVID-19, to miss medical appointments and potentially interrupts their ability to acquire medications. Lastly, the use of stigmatizing language in medical practices and limited access to culturally appropriate resources are examples of other barriers that can contribute to reduced access to medical care. As we continue to learn more about the impact of COVID-19 on the health of different populations, immediate action is critical to reduce disparities among the populations known to be at disproportionate risk. CDC's guiding principles are to reduce health disparities, to use data-driven approach, and to foster meaningful engagement with community institutions and diverse leaders. In addition, we aim to lead culturally responsive outreach programs and to reduce stigma, including stigma associated with race and ethnicity. We have 4 strategic priorities to reduce the disproportionate burden of COVID-19. We are striving specifically to expand the evidence base to increase the understanding of the impacts of COVID-19 and of the factors that lead to its disproportionate burden on racial and ethnic minority populations. We seek to expand testing, contact tracing, isolation options, and care to reach populations that have been put at increased risk. We are striving to expand intervention activities to support essential and frontline workers to prevent transmission of COVID-19. And lastly, we are seeking expansion of an inclusive workforce equipped to assess and address the unique needs of an increasingly diverse U.S. population. CDC intends to continue to partner with physicians, epidemiologists, researchers, public health practitioners, and state and local department officials to implement its health equity strategy. CDC is acting to address long-standing pre-COVID health and social inequities that put many people from racial and ethnic minority groups at increased risk of getting sick and dying from COVID. For example, this is being done by providing assistance to public health agencies and others to expand testing, contact tracing, isolation options, and medical care to reach groups at increased risk for getting COVID-19 and having severe illness. Secondly, we are proceeding by also facilitating partnerships between public health agencies, tribes, scientific researchers, professional organizations, community organizations, and community members with the goal of sharing information and facilitating collaboration to prevent COVID-19 in racial and ethnic minority communities. CDC is also offering technical assistance to local communities with COVID-19 outbreaks in areas with disproportionate impact on workplaces that employ low-wage workers. For example, meat processing plants, agriculture, and nursing homes. In addition, we are taking action to address health and social inequities through the following. We are supporting essential and frontline workers to prevent the spread of COVID-19 in critical workplaces. We are developing guidance to implement programs and practices that are in different languages and that also are culturally tailored to diverse and unique populations. And lastly, we continue to build an inclusive public health workforce that is able to understand and meet the unique needs of an increasingly diverse population. As a final thought, we continue to collect and assess as well as track disparities related to COVID-19, working specifically to expand completeness of the data and to develop new ways of communicating data to the public and to other key decision makers. We all have a part in helping to prevent the spread of COVID-19 and in promoting fair access to health. To do this, we have to work together to ensure that people have resources to maintain and manage their physical and mental health. This includes having easy access to information, to affordable testing, and to medical care. We need programs and practices that fit the communities where people live, learn, work, play, and worship. A longer list of actions can be found on CDC's COVID-19 webpage for health equity under the section, What We Can Do. In closing, we encourage you to learn more about CDC's Chief Health Equity Officer Unit, about health equity, and about the COVID-19 Health Equity Strategy by visiting our webpage. We are grateful for all that you do for our communities, for your dedication to scientific innovation, and for your interest in drawing attention to our work as we move the nation forward to reduce COVID-19 health disparities and achieve greater health equity. Thank you.
Excellent. Thank you so much, Dr. Hall, for such an informative presentation. We are collecting questions in the chat box for Q&A at the end, but I see one sort of clarifying question, so I'm hoping, Dr. Hall, you can answer it briefly. Does the CDC disaggregate the racial data to recognize unique ethnic data?
Thank you for that particular question. This aggregation has been an active part of the conversation within our agency, and our unit currently is exploring possibilities for this aggregation where the numbers will allow. I do have to provide a little bit of a caveat with that particular statement because, as you know, some of the ways we present data are subject to our ability to do so without potentially jeopardizing privacy, for example. So within the scope of those constraints, we are very much moving intentionally towards providing data that are appropriately disaggregated.
Great, thank you so much. Next up, we have Tammy Jo Hill, who is a policy specialist in NCSL's health program, who will be providing an overview of legislative trends and state examples regarding this issue. Tammy Jo, please take it away.
Hello, everyone, and thank you, Dr. Hall, for that excellent presentation. As Kyne said, my name is Tammy Jo Hill, and I'm a policy specialist on the health team here at NCSL. Among other topics, I'm helping to track legislation, policy options, and best practices related to health disparities. Today, I'm here to give you a better understanding of these areas in 2020. So let's go ahead and just jump right in. Since January 1st, 2020, we have tracked at least 160 bills across 26 states. Of these, at least 53 have been enacted. Common themes to the legislation we are tracking include creating task forces, requiring data to be collected by race, appropriations to identify, analyze, and address health disparities in access and health outcomes. Other topics of conversation and policy options we are tracking related to equity and access to clinical trials. However, at this time, we haven't received much information about this legislation, more about informational inquiries as it relates to this topic. Next, I would like to highlight a few state actions in both the legislative and executive branch. This year, North Carolina enacted House Bill 1043. This bill appropriated CARES funding to state and local reserves. This money has gone to working with nonprofit organizations to target rural areas and African American communities to help with outreach, health education, and testing to address the COVID-19 disparities in North Carolina. Similarly, Vermont enacted House Bill 965, which appropriated CARES funding to state subgrants. One of the subgrants directs the Department of Health to engage communities most affected by COVID-19. The Department of Health shall work to assess and support needs related to shelter, food, healthcare, and emotional support. In New Jersey, they are currently working on Senate Bill 2410. This Senate bill will establish a coronavirus pandemic task force on racial and health disparities. The task force has a number of priorities, including conducting a thorough study on ways in which and why COVID-19 has disproportionately impacted minority and vulnerable populations, ways in which to improve existing data systems, evaluating issues to the quality of and access to physical and mental health treatment, and to solicit and receive testimony from members of the state's minority and vulnerable communities about their experience with COVID-19. The task force will also develop strategies to address racial, ethnic, and health disparities and historical systematic inequities pertaining to race and ethnicity that have been amplified by COVID-19. They will work to reduce and eliminate these disparities with respect to health status, access to healthcare, and utilization of healthcare services. They will evaluate communication, messaging, and dissemination of information regarding testing, contact tracing, and other related public health approaches as necessary to achieve healthcare equity and cultural competencies in physical and mental health treatment and services. They will evaluate impediments that interfere with individuals' ability to quarantine or isolate during the pandemic. They will work to analyze the distribution of resources, including personal protective equipment and food. They will examine impact to essential employees and child health care services, as well as investigate the prevalency of intimate partner violence and identify best practices and opportunities for shared services or potential partnerships that could increase the communication of healthcare information and materials in multiple languages. In Louisiana, they have enacted House Resolution 61. This resolution urges and requests the Department of Health to study and report on the matter of racial disparities in COVID-19 deaths in the state. This resolution was passed after the House passed House Resolution 294 and Senate Resolution 240 in 2019. These resolutions worked to address racial disparities in maternal and child health outcomes, as well as research from the Louisiana State University Health Science and Child Health Outcomes in New Orleans that examined coronavirus patients at the onset of the pandemic to help better inform decisions for the resolution that they passed here in 2020. Ultimately, this resolution also states that the Department of Health shall engage with the governor's COVID-19 Health Equity Task Force and submit findings to each member of the House of Representatives and the Secretary of the Louisiana Department of Health to help them better understand the scope and needs of their community moving forward. We have also seen and tracked a number of actions at the executive level. In Illinois, they have created the COVID-19 Health Equity Task Force. This task force is composed of members from the Illinois Department of Health, state and local agencies, and community partners statewide. The task force will seek to identify emerging issues and patterns impacting medically and socially vulnerable communities, and then assess and propose specific actionable recommendations. They will amplify critical unmet needs to key leaders and propose equitable solutions. They will provide timely equity and equitable analysis on systems to maximize benefit and avoid harm and inequitable outcomes for communities of concern. They will track and follow issues and recommendations to resolve and communicate back to key members and communities of concern. In Utah, the governor has passed the COVID-19 Community Task Force. Most recently with this task force, he has created a subcommittee to ensure that vulnerable and underserved communities receive news and information related to COVID-19. This subcommittee will also utilize a survey that was conducted by the Division of Multicultural Affairs as their baseline. The survey, which the link is here on the slide for you, found that minority, low-income, and other underserved communities face challenges with their basic needs, limited technology resources in their area, challenges with access to healthcare, and language barriers. The document published from the survey, Local Needs Among Utah's Multicultural Communities During the COVID-19 Pandemic, includes recommendations that the subcommittee will use to address the most identifiable issues. As always, NCSL is here for you. We have provided a few resources on this slide for you to continue to track legislation throughout the rest of the year as well as into 2021. We anticipate that this area will continue to be a topic of discussion and something that we will focus on for several months to come. If you have any questions, please don't hesitate to reach out. Thank you.
Thank you so much, Tammy Jo, for providing those state examples. Our next presenter is Alicia Nelson, Director of Recovery Ohio and co-chair of the COVID-19 Minority Health Strikeforce in the Office of Governor Mike DeWine. Director Nelson will share Ohio's response to COVID-19's disproportionate impact on different communities. Director Nelson, thank you for joining us.
Thank you for having me. I really appreciate the opportunity to talk a little bit about what Ohio has been doing as it relates to these issues. I'll go ahead and go on to the next slide and appreciate the introduction. As she stated, I am the Director of Recovery Ohio, which is an initiative within the governor's office that looks at mental health and addiction, but have been a long time worker in equity and has talked a lot about equity as it relates to behavioral health concerns in the mental health space and the addiction space. And so it was a natural fit for me to respond when the governor requested to put together a minority health group around COVID-19, and really has been an honor to serve and learn so much with health professionals across the state of Ohio and all of you across the country. Today I'm going to talk a little bit about Ohio's response. I'm going to talk about our trends, share a little bit about our strike force, which sounds a lot like some of the other strike forces that have happened across the country, hopefully share a little bit of insight of what we've done that may have been a little different or unique to Ohio along the way, and then really talk about some of our long-term responses as well and highlight those. To start, I want to spend some time talking about Ohio's data. Early on, we knew we had to trust our scientific and population health experts as we worked to navigate our responses to the many unknowns of COVID-19. And in March, Ohio was one of the first states to take some aggressive steps to really slow the spread of the disease. And by April, we really started to see some of these disparities clearly in the data. And so the governor created the COVID-19 Minority Health Strike Force. And at that time, when we started the Strike Force, Black Americans had represented more than 26% of the total cases, over 31% of hospitalizations, and 19% of the COVID-related deaths. What you see on the slide here is that today, after our work in partnership with many federal, state, and local community partners, we have been able to see some improvements in our numbers. And what you see here is that right now, as of October 11th, we although African Americans, Black Americans represent 13% of Ohio's population, they make up now 19% of the cases, which is a significant improvement, but we still have a ways to go to really support our communities of color. And we're seeing some of those similar improvements, but still have a ways to go. And I appreciated the conversation about disaggregated data because that's something that we need to, and we have been looking at as well here in Ohio. To start this work in April, we really wanted to bring folks together, much like you heard other states had done, and have conversations with our community leaders.
We've had over 1,000 phone calls, and, I really need to update this because it's been quite a few more than that since we've done this slide. We had 8 and more Minority Health Strikeforce meetings, and really talked to folks from across the state, and really wanted to bring town hall folks together to just have a conversation about what were the needs, what were they experiencing, what were they seeing as they worked to address this crisis. What became clear to us is, and this is an example of one of our surveys, is that there was some work to do in the healthcare space. There were also survey results around resources, survey results around other aspects, data, for example, and then community marketing and messaging. But right now what I'm showing you is some of the results of our Strikeforce talking about healthcare. And really what we saw is that a lot of folks really wanted us to focus on implicit bias trainings. They talked a lot about limited access to testing, treatment, and personal protective equipment, PPE, which has become a kind of common acronym since COVID started. A real conversation and robust conversations about lack of trust with medical professionals, and then limited access to health insurance coverage, that was discussed earlier. So a lot of the same themes that we heard in some of the other states across the country earlier today. So we got together in April, and by May we had released our first interim report. And this will be the first of 3 reports that we've released so far from this group that are really addressing, and this is the only one that directly addresses COVID-19. What we came up with was 18 recommendations that really looked at ways we can stop the progression of the disease in the communities of color that we were trying to impact, evaluate and document the impact of disease, as we talked about a lot of the needs in data, a lot of needs in disaggregated data, and understanding what's happening where. Ohio has a large migrant farming population, as an example, and seasonal and agricultural workers. And so we needed to understand what the response looked like in all communities. Another large population that we don't often talk about is our Amish population that's prevalent here in Ohio. And we wanted to make sure how we can best help all those who could be impacted in our state. We talked about remedying factors that contribute to spread, and this really got to messaging in translated languages, and really talked about how a lot of communities of color, or some individuals from communities of color, may work in critical occupations and may live in environments that may not allow for social distancing. In my community, we have generations of families in a household who have younger members of the household who had to go out and work and expose themselves, but also live with their grandparents. And so what are some things that we can do to support them? All of those things were included in our interim report, and I'm glad to say that we've been working through those, making them available on our coronavirus.ohio.gov. We made a specific page, and the branding that you see, this vibrant green color, is a part of our branded campaign around more than a mask. We want to give you the resources and tools that you need to protect our communities, to protect our families, and to feel safe in this environment, and put that all into a website, and really promoted that through our More Than a Mask campaign that you'll see some of the imagery here, to make sure that folks are staying informed, staying involved, and staying inspired in a time where, all of us has really seen this to be a difficult year, but really keeping that hope and that those conversations of togetherness and having those informed conversations about what's available to support those who need it, and what are the facts as it relates to COVID-19, as misinformation has been a theme in some areas. We also spent a lot of time talking about, in our COVID response, access to testing and what we can do. And this was all identified in the Strikeforce Interim Report that I just shared. But one of the things that struck us is how can we put partnerships together that really allow for long-term support for individuals. And so we work closely, thanks to the federal government, thanks to our community health centers, with those community health centers to identify testing locations throughout our site, to make sure that people establish relationships with those community health centers as they were tested, to make sure follow-up appointments and primary care relationships were established as a part of our COVID-19 response, so that there be some of those meaningful conversations, not just about COVID-19, but beyond, and really connecting people to contact tracing services in a way that made them feel comfortable to share their information. We heard that a lot early on about the importance of trust, and having those trusted community partners was key for us. The second report that I'll go through really quickly was released in August. It had 34 recommendations, and the purpose of the second report was, now that we were really starting to see improvements in COVID-19, and there's still work to be done, don't get me wrong, we wanted to really talk about why these disparities happened in the first place, and had real conversations with our Strikeforce members about ways that we can look at disparities, understand the role of racism and discrimination, and really start to identify ways to advance equity in our state, and talk about racism as a public health issue, and really understand our role as state partners, both public and private, in advancing equity. And so this report was kind of a blueprint, and I think that's why we stuck with that name, on how communities can start having conversations, meaningful conversations about racism at a time where so many people were interested in having those conversations. From that report, we released our third report because we wanted to, show how that blueprint could be used by community organizations or by public or private entities. So we put together the Ohio's executive response, a plan to address and advance equity, and had all our executive directors sign on to be a part of the solution in advancing equity and really dismantling racism, and hopes that we can make Ohio, the state of Ohio, a model employer, a model business, so that others can really join these conversations and see ways to improve the experience of their employees and Ohioans. We've done a lot in this work, and this is all available on the coronavirus.ohio.gov website. I know I went quickly through this information. It's just a kind of brief overview of what Ohio is doing. I'm happy to answer questions. Really thankful for the work of NCSL for putting this together. We continue to see improvements in our COVID data, but we know this is just a start. We have a lot of work to do to address disparities, and look forward to continue partnerships with the legislature at the state and federal level, and really hope to see improvements not only in COVID-19, but in things like infant mortality, addiction, mental health, air quality. We're looking at all those things in our executive response to make sure that we really improve the health and well-being of all Ohioans. So thank you all for having me.
Great. Thank you so much, Director Nelson, for sharing the work that your state is doing in this area. We will now go to general Q&A. I see that we do have some questions in the chat box. Hopefully we can get through quite a few of them, and thank you, Dr. Hall, for starting to respond to some of them in the chat as well. Director Nelson, I'll actually direct the first question to you. Can you share more about the membership of the Strikeforce and tips around engaging so many stakeholders from different sectors and communities?
Sure. It was a process for us. We definitely learned from our survey results that, communities want to talk to someone they trust. And there seemed to be, if we, work with our different communities around the state, those trusted individuals had an inroads into information that we just couldn't get at the state government level. And so what we did was brokered a partnership with those individuals who had the trust and the respect of the community to bring them to the table and kept ongoing conversations, asked them to, and in some cases they put together their own town hall conversations where we just joined the conversations as a guest to learn in an environment where they felt safe what they needed. And I think that was an important part. Specifically, we had business leaders, members of our state legislature, our state employees, including our Commission on Minority Health, our health department, our Hispanic Latina Commission, joined the group as well. It was a pretty robust group.
Great, thank you so much. The next question will be directed towards Dr. Hall. Some surveys have shown that most Black Americans do not plan to get the first COVID vaccine. Can you share your thoughts on this low confidence or trust and what you might recommend to build or recover trust? And I'll pose that first to Dr. Hall, but Director Nelson, if you would like to add anything, please do jump in.
Okay, yes, I'd be glad to address that question. I did just drop a little bit of information into the chat as we were talking. I just saw the question as it was posted there. And if you take a look at the response that I just gave, one of the things you'll immediately see is that the answer to that particular question is actually very complicated. CDC and state and local health departments are actually taking a very close look at a variety of different strategies to possibly reduce vaccine hesitancy. And one of the reasons why it is a bit of nuance is required is because, even though statements tend to be aimed at population groups as if population groups are homogenous, one of the things that we know is that's not the case. And so there are activities that are occurring such as listening sessions that are designed to really kind of, get at these specific sources of concern and sources of mistrust potentially to be able to speak to those particular barriers to vaccination right where they originate in terms of the communities where vaccination work will need to occur. So the answer to it is a little bit more complicated. I think that the issues of trust may differ by community, and the specific approach that might be needed for a particular area may be a reflection of the history of that area, with health systems in general, as well as with their public health systems in terms of their knowledge of processes such as these. So that is just one sort of set of thoughts about how this is being approached and some of the complexities that lie therein.
Thank you, Dr. Hall. Yes, please.
I was going to say, I can just piggyback off of that. I agree with Mr. Hall. And Ohio is using the framework of equitable allocation as a part of our response for vaccine allocation. And what we have talked about to add on to his comments is some of the communication strategies that we'll need to explore as it relates to just breaking down myths and educating communities. We will be looking at, population-specific communication strategies. Again, going back to those trusted individuals in the community and sharing the facts as we know them. I think that, over the next couple months, it's going to be critical that we share the evidence and the science that comes out around the vaccine, and just continue to work to communicate the facts over time so that people can understand and understand the vaccine and its importance, and establish some trust in that tool to help us mitigate COVID-19 and get us to a spot where we can control the disease.
Thank you both for your responses. Next, we'll take a question about other ways to possibly assess or measure progress on COVID health equity besides case rates, hospitalizations, and deaths. Again, I will pose that first to Dr. Hall, and if Director Nelson, you want to add anything, please do.
Yeah, thank you. I think that this is a good question. There are a variety of other variables that people don't often think about. Case rates, hospitalization, deaths, those are the ones that are most commonly addressed. But there are impacts on health-related quality of life variables that are also important to capture. We know, for example, that the effects of the mitigation strategies and of COVID in general for some of the institutions in our society have been far-reaching. And so one of the things I know that our agency is very much interested in is being able to capture a wider span of impacts on, the ability of different populations to pursue health and to participate in those things that make life meaningful for them. So that begins to get you into other areas such as the consequences of the mitigation strategies for employment, for example, and how that feeds over into areas such as being able to satisfy, the vital conditions of health, or to be able to address basic needs. Food security is an example of something that we have seen come up lately. And there's also been a lot of conversation about things such as housing security. Those two things tend to come up in conversations in parallel. So there are a variety of other outcomes and other social variables that are critical to take a look at, because they are very influential where the ability to pursue and maintain health is concerned. What I would also encourage people to think about is this idea of impacts on the ability, for example, to maintain chronic conditions or just chronic diseases that may have been present pre-COVID. We've seen ripple effects across conditions such as to those such as sickle cell disease, where the drug testing situations, for example, may have, caused a temporary sort of surge with respect to certain medications that might have been very essential for persons with sickle cell disease. My point is there are a number of other sort of ripple effects that are associated with this pandemic that really need to be characterized beyond just simply those three that were introduced in the comment section there.
Thank you, Dr. Hall. I think we have time for just one more question. Let's see. We have a question about disparities with other racial groups. So Asians have a number of pre-existing conditions that lead to COVID complications, such as diabetes, hypertension, certain cancers. Has anyone looked at why the disparities are different for this population? Sorry, that question I would direct towards either CDC or Director Nelson, if you've seen that in your state and have looked at those numbers.
I can speak from Ohio's perspective. So what we have done is use the CDC vulnerability maps and then mapped into that some of our clinical vulnerability information. We did see disparities across different groups, including Asian Americans. And so what we've done is try to put our pop-up testing sites in areas where communities of color live and can access that information, whether it's a pop-up testing site that operated in the evening, on the weekend, in the morning. Make sure that folks who are aware of that information and really have continued to engage in a dialogue. I think that this goes back to, what else can we do after COVID goes away? Goes back to equity in addressing disparities overall. I think we see a variety of issues across communities of color that need to be, unpacked, understood, and we still are in the early stages of that as a committee. Although many of our health and population health folks will say that they've been working on this for a long time and these types of things for a long time. So I hope that gives some perspective of how Ohio has used that information to really impact our COVID response, but still a lot of work to do long term.
Great, thank you so much. And thank you everyone for sending in your questions. Unfortunately, we are out of time to get to all of them, but questions not answered on today's webinar will be answered via email. Before we end, I want to let participants know that this webinar is part of a new health equity project at NCSL, and we plan to continue to work on health disparities and equity through legislative tracking, virtual meetings, and other resources. We will be convening a health equity advisory group to provide guidance to our work. And in partnership with the Quad Caucus, NCSL will also host 2 town halls to dive deeper into the topics of health equity and disparities and provide a space for state-to-state dialogue and the exchange of ideas, successes, and challenges. More to come on these opportunities soon. We would like to extend a final thank you to our presenters. We greatly appreciate the expertise each of you shared today. And thank you to all our attendees for participating. As a reminder, a recording of today's webinar and the presentation slides will be available on NCSL's website. This concludes our webinar. Have a great day and stay well.